We know p53 plays a central role in cell apoptosis. p53, however, is negatively regulated by MDM2, which is overexpressed in myeloproliferative neoplasm. Navtemadlin is a potent oral inhibitor of MDM2. In doing so, it restores p53 function. This forms the basis of our study, the KRT 232101 Part A study. This was a global phase 2 open-label study in which patients who were relapsed or refractory to prior JAK inhibitor therapy, primarily ruxolitinib therapy that is, were enrolled in one of 4 cohorts. The cohort of most interest is cohort 3, whereby patients were dosed at 240 milligrams on days 1 through 7 of a 28-day schedule. Overall, 113 patients were enrolled. These were either primary or secondary myelofibrosis patients who were relapsed or refractory to ruxolitinib, and they had platelets above 50,000. Patients who were only intolerant to ruxolitinib therapy were not enrolled in this study. So this was a primarily relapsed refractory to ruxolitinib myelofibrosis study. Like I said, 113 patients were enrolled across 4 different cohorts. The primary endpoint was spleen response rate at 24 weeks through central radiology confirmation. The goal of the presentation today was to show the results of the correlation of disease-modifying endpoints or biomarkers with the survival outcomes. To that end, in this study, we looked at various disease-modifying biomarkers like cytokines, variant allele frequencies, as well as CD34 cell counts from peripheral blood. Also, bone marrow fibrosis was assessed at different time points during the study. Chiefly, the peripheral blood studies were done at baseline, week 12, week 24, and subsequent to that, every 24 weeks. The overall survival in the cohort 3, which is the dose and schedule chosen for the phase 3 study, was not reached after a median follow-up of almost 38 months. Importantly, disease-modifying endpoints or markers like CD34 cell count reduction to normalization correlated with the survival endpoints of PFS and OS. So these were improved in those who had CD34 normalization as compared to those who did not. Similarly, a variant allele frequency reduction by 20% or more of the driver gene correlated with improved PFS and OS. These exciting clinical results, including the spleen responses and symptom improvement that was noted in the phase 2 study, more so in those who had ruxolitinib washout, as well as the expected on-target disease-modifying activity of navtemadlin, has led to the design of an ongoing phase 3 study whereby patients with relapsed refractory myelofibrosis are randomized to navtemadlin at a dose and schedule of 240 milligrams on days 1 through 7 every 4 weeks, or best available therapy, with the primary endpoint being spleen response rate at week 24.